Here. I'm excited to welcome our next presenter, someone who's new to our elective, but certainly not new to the field, in Mike Lubin. Michael is currently the Vice President of Growth at, is it Aledade? Am I pronouncing it right there, Mike?
That's correct.
Perfect. At Aledade, a leading primary care solutions company focused on helping sustain primary care physician independence through success in value-based care. Aledade is a leading enabler of primary care physician-led ACOs in the US. And you don't worry if you don't know what an ACO is, you will by the end of this talk. Aledade currently operates 35 MSSP ACOs across 31 states, as well as 47 other value-based care partnerships with nearly every national commercial insurer. Aledade currently partners with over 7,800 primary care physicians and manages over 1 million patients in risk-based contracts. Again, don't worry, if you're not sure what that is, you will after this talk. Michael began his career in strategy consulting, serving Fortune 500 clients in healthcare, technology, and food industries on issues of growth, innovation, and future scenario planning. In 2006, Michael refocused his career on the healthcare industry, building technology-driven businesses that address underlying issues in the US healthcare system that contribute to industry cost unsustainability. Prior to joining Aledade, Michael was a founding team member at Hint Health, the leading direct primary care solutions company, where he led strategy and growth, dramatically expanding the direct primary care industry nationwide. Prior to Hint, Michael co-founded Intune, a clinical integration solutions company that enabled large primary care IPAs to drive continuous improvement in costs and quality to improve economic success. Welcome, Mike Lubin.
Thank you. It's great to be here, guys. Really appreciate the time that people took to participate in today's discussion. Maybe I will get my slides up here and we will start rolling.
And as a by the way, people should have their poll everywhere attendance link up, but just know that we're going to be leveraging a couple different polls through poll everywhere. So just have that ready to go. Have your phone out with your app or that browser tab up as we move through the session.
Excellent. And so just making sure, double checking, everyone can see my slides up. Payment, ACOs, and alternative payment models being the first slide. Great. Awesome. Terrific. Well, again, thanks everybody for having me here today. It sounds like it's been a marathon day, so I might be the person that brings you home. So hopefully this will be an interesting presentation for you. A little bit of background, I mean, beyond what was shared. The majority of my career for 20 plus years. There was, I had a personal epiphany probably about 18, 19 years ago, where I was in management consulting. I started doing more and more work in the healthcare sector for some large insurance companies, large healthcare systems. That's when I got my kind of deep fundamental education on how the US healthcare system is structured, how it works economically, the incentive structures that are within it. And quite frankly, that epiphany led me to a tremendous desire to work within the healthcare sector, in healthcare, and quite frankly, try to start companies, be part of companies that help to solve the root cause issues that are underlying, the unsustainable growth in cost and spend in our industry. And quite frankly, we should all be unsatisfied with some of the outcomes based, in terms of ratio to spend as well. So that became a personal passion of mine over the last, 15 plus years, and have been involved in 3 great companies that have been focused on helping to solve those problems with a pretty big emphasis on the primary care segment of the healthcare provider landscape, in particular, independent primary care segment, which, as we uncovered today, is a really critical component to a healthy, cost-effective, high-functioning healthcare system. So today's stories will be a lot kind of coming from a lot of that background that we'll be talking to, and hopefully, guys, get you up to speed. Please, questions along the way, feed them in. I do want to make the session interactive today. There'll be a couple of polls, I think 3 polls that we'll do to get your thoughts on some topics along the way in the presentation. I'm also hoping to save some time at the end, about 30-ish minutes, where I've got a little kind of mini assignment, kind of thought exercise that I'd love to break out the attendees into 3 groups for you to think about some payment solutions to start to see your thinking based on what you learned today in the context of what we'll be talking about. So hopefully it'll be interactive. All right. I'm not going to review the learning objectives. You guys should know those coming into this course. I do want to start, though, just with a quick poll, just to understand who we have today. Medical students, policy students, interested public, healthcare providers, others. So I think there may be a poll that's coming up now for you guys to answer, just so I've got a sense of who's in the audience.
So everyone should be able to access this question on Poll Everywhere. And I'm simultaneously going to share my screen so that we can start to see the responses in real time. So I am also sharing my screen, and you should be able to toggle down to see my see the results of Poll Everywhere just shortly. Boom.
I am not sure how I can see that, but you could just you could certainly just let me know too what the results are.
Yeah, so we have 50% medical students. It looks like we have a couple people from interested public. We have some public health students, healthcare provider, and a few people that identified themselves as other.
Perfect. Awesome. Really helpful. Thanks for sharing that. Helps me understand who's in the audience today. Okay. So let's take you on a little bit of journey here. When we think about talking about how healthcare is paid for, I always love to start that discussion with helping kind of framing the big picture problem that we're ultimately trying to solve when it comes to payment, the U.S. healthcare system, which is, as this audience probably knows, we spend an enormous amount of money on healthcare, well north of $3 trillion a year at this point. It has been very well documented that at least $1 trillion of that $3 trillion is waste. And waste can come in lots of different forms. We'll be talking about that as well. But the way that we pay for healthcare and the economic incentive behind how we pay for healthcare is a major contributor to this problem, as we'll be learning about today. So that's ultimately, where concepts like new payment models, the concept of ACOs, which we'll be talking about, are really single-handedly designed to try to solve for this issue. Again, probably data you guys have all seen before, but man, we spend a lot on healthcare, right? Vastly more than almost every other developed nation in the world, significantly more than any developed nation in the world, and growing significantly year over year. So we spend more, right? Our per capita spending also almost twice as much as individuals in other major developed nations. So not only are we spending enormous amounts in this industry, but everybody on this phone calls, participation in that spend is very significant and also growing significantly year over year. The thing that makes the U.S. healthcare system so unique compared to other developed nations, quite frankly, is this concept of the bifurcation, rather, of we have a publicly funded healthcare system, the federal government in Medicare and Medicaid, broadly speaking, but then we have this very significant other segment called private healthcare, which I think you guys have been studying a little bit. The private healthcare sector, which is really what differentiates us from other developed nations. 48% of Americans access their healthcare benefits today from their employer. That's not the case in other developed nations. So that bifurcation of federally funded and financed healthcare and private healthcare really is the big differentiator between us and other developed nations. This chart just shows kind of a population breakdown, right? So 150 plus million people in the country out of our total population are receiving their healthcare benefits through the employer. And the way that those two industries are structured is different. And that's not only a big differentiator between us and other countries, but it's also, as we start to peel the onion here, a huge driver in the underlying kind of cost and spend increases in the healthcare system as well. As I mentioned, private healthcare expenditures are making up more than half of our spend, and growing very significantly. The private sector spend is also increasing much faster than the public sector spend. So this kind of, this private health insurance industry and employer-driven healthcare is not only huge, almost half of what our spend is, but growing faster than what the federal government is spending on healthcare in the public sector. Again, apologies if you guys have seen a lot of this data, but it's important. I think it's good foundational data just to reinforce. Now we want to kind of start to take a look at where is that spend going? What are the major categories of spend in the US healthcare system? And as we can see, probably not surprising, hospital care, right, is the biggest consumer of healthcare spend in the country. Followed pretty quickly by the professional services segment. So that's healthcare providers, right? Non-hospital based healthcare providers. Think primary care doctors, specialist doctors. They're the second biggest category. And I wanted to pull out or just note in that category in particular that, within that very significant spend, 26% of our spend on professional services, approximately 6% of that is primary care. So the primary care spend amongst that professional services segment is actually really a small component of it. The rest is specialist spend. So it's important just to understand, that kind of spend segmentation as we start to learn about, as we start to think about and start to learn this class about alternative payment models, a new way of spending, a new way of paying for healthcare, and what segments of providers, whether it's hospitals, specialists, or primary care, we should think about focusing our efforts on changing out and changing the incentive and how healthcare is spent as we get into it here.
Mike, if I could ask a question here, back
Please.
to that original slide there. Where do preventive services fit in here? Would that be government public health activities or?
So, preventative services, generally speaking, are predominantly delivered by the primary care sector.
Okay.
The primary care sector is going to be, depending upon the patient, where the patient is getting their, who the patient's payer is for healthcare. If they're 65 and older, right, they might be a Medicare beneficiary. So those preventative services are going to be delivered traditionally by or predominantly by their primary care physician, but in that case, paid for by Medicare. Where I might be an employee of a company in America where my employer is providing the benefits, and maybe my employer has brought on, Aetna or Humana or United Healthcare or Anthem to provide our benefits. In that case, my employer, is financing the healthcare through a private sector insurance company. But the primary care segment's delivering the preventive services for the most part. Make sense?
It does.
Okay. So the one thing I do love to point out too is that it's really interesting when you take a couple steps back, and it's one thing just to say, wow, we spend a lot of money on healthcare in this country, and sure, it's growing. The other thing, just to sensitize everybody too, is that we don't have unlimited dollars in America. So one of the phenomena that's happening, and has continuously happened over the last few decades, as the size of the healthcare spend pie has grown, is those dollars and resources we're having to reallocate dollars and resources from non-healthcare spend in order to afford to continue to spend the money that we're spending in the healthcare sector. So as our healthcare spend as a nation continues to grow, this is just, this is one of the things that drives me personally crazy is that it's defunding, right? Or it's decreasing our ability to spend and invest in other segments of society, whether that's that's your personal budget, whether it's education, whether it's welfare related spending, the other non-healthcare kind of budget line items, if you're a state or local government, even if you're a family, are suffering as we spend more and more money in healthcare each year, which I think is just an important point for people to understand. To that point, right? In many ways, healthcare costs are undermining financial security of the American family, generally speaking. Despite the fact that we have pretty good health insurance coverage in our country, right? High 80s, low 90% typically these days. So most people have some form of insurance. The reality is that as healthcare costs and the cost of healthcare has gone up, Yes, you may have insurance, but the amount of coverage that you have is probably been declining over the last 3, 4, 5, 6, 7, 8, 10 years, meaning that health insurance companies have had to cost shift to you to help you also contribute to the rising cost of healthcare, typically in the form of like insurance deductibles or copays, which I'm sure everyone on this in today's meeting is familiar with. Today, 1 in 50 people that have insurance have out-of-pocket costs that are greater than $5,000. 1 in 200 have out-of-pocket costs that they're responsible for that are greater than $10,000. The average savings that Americans have in the bank is typically ranges around $3,000 to $5,000 for a typical American family. What that means is that if you have one bad healthcare episode, even if you have health insurance, you could be facing financial disaster because you just don't have the money to pay for the out-of-pocket cost component to your health insurance. It's just one of the phenomena that's been emerging over the last 10 plus years that's been exposing American families to. Medical expenses are simply the leading cause of bankruptcy in the United States. 66% of bankruptcies in 2019 in America were the result of somebody having to file bankruptcy because of medical costs they couldn't pay. And many of those people had health insurance. So this phenomena that we're seeing of healthcare cost growth, right? And the spend increase isn't just a problem unto its own. It's starting to really affect society in fairly profound ways because of how much dollars it's consuming annually and the way it grows. These were quite frankly, these were some of the things that I was noticing, 15, 18 years ago that made me very motivated to want to help to solve some of these problems. So we've got another poll coming up right here. So we've talked a lot so far about this concept of healthcare spending. We've talked at a high level about how healthcare spending is happening both by the federal government as well as in the private sector, and that it's very large and growing. I'm curious to understand what the class's perspective is, and guess if you don't know, and these aren't easy answers, what do we think is the one key factor on this list that's driving healthcare spending growth? Is it the size of our population and the fact that we're growing as a nation in terms of number of people? Is it the age of our population and the fact that we have an aging population? Thus, as you get older, you need more healthcare services, and that's the big driver. Is it disease prevalence or disease incidence? In other words, we have our population's getting sicker every year, so that's the driver of increasing utilization of healthcare costs. Is it service utilization? So just more people are using healthcare services more often and more of it. Or lastly, is it service price and intensity? Is it the price? Do we have prices going up and that's what's driving it? So I'm curious, those are, one of those is the answer. I'm curious what the class thinks the one big driver is of healthcare spending in the US.
So as of right now, we have 70% of people think it's the service price intensity, and 30% of the people think that it's population age. Oh, population age just got another vote.
This is great. It's like election day. How are we doing now?
So
we may have a winner, but you never know. We're not at the end.
65, 35. And I think we've reached everyone that is going to.
Are you going to call it?
Yeah, I think so.
Okay, awesome. Love it. We've got some smart folks in the room. Both good answers, but the clear problem, right? And by the way, this is a title of an article, and I've got some suggested reading for you guys to consider at the end. This is the title of one of my favorite articles. It was in New England Journal of Medicine several years ago. It's the prices. It's price intensity. We have a huge pricing problem in our U.S. healthcare system, and there's a lot of reasons that contribute to that that we'll be digging into. But that is the major driver of our healthcare spend and our spend increase year over year. So this is back to the chart we were just looking at. By far, right? Service price intensity is the significant driver, more so than any of the other factors that we touched on, or that you could have considered in that answer. And as you take a look at service, if you take a look at service pricing across both healthcare procedures as well as prescription drugs, I mean, and compare that to other developed nations, literally, it's like across the board, our pricing is dramatically higher than other developed nations by a significant margin. These are just some sample pricing that came out of a study in 2012, and this was quite some time ago, that compared, an average price in the U.S. for certain procedures versus the average price in other developed nations. And again, this just illustrates the significant price difference across these particular subset of either drugs or procedures. Pricing is the big driver. So question, we have our third poll here. What do you think is driving up the price of healthcare services? And so this is kind of an open-end question. People can provide answers or commentary that they think might be the answer here. What do we think is driving up the price of healthcare services?
So we have one answer that's come in. They said greed. Another person has said absence of regulations, monopolies, insurance competitions, too much administration, profit-driven market, or just profit, high physician wages, hospital administrations treating health as a business,
good answers.
Yeah, I think that may be our last one. Oh, admin again.
What was that last one?
Admin again. Lack of regulations for prices again. Privatization versus public care.
Good.
I think those are our responses.
Awesome. We've got a smart crew here. Everyone's onto it. I mean, there's a lot of dimensions to the answer to this question. This is not as simple as our last poll question, where there's demonstrable evidence of that being the problem. And quite frankly, that problem is a problem that the industry doesn't want anybody to know about. And we may talk about that a little bit. There's a side story there, but those are great answers. Yeah, there's really 5 dimensions to this answer, each weighing in and impacting this problem. Number one is, I think somebody had said monopolies or monopoly. Yes, absolutely. Increasing market consolidation and concentration is a big issue and a big contributor to increases in pricing. As everybody in this class probably knows, right? We've been in a wave of market consolidation in the U.S. healthcare system over the last 15, 20 years. It seems like every community that you roll into in America, the local hospital or health system has now been buying up the local independent primary care doctors and specialists in their market to try to create more market power and a monopolistic kind of situation. So that's a big one. Number 2 is tight and restricted physician labor supply. So physician labor is regulated in this country in terms of the number of physicians that we can produce. That creates a problem in terms of just supply and demand dynamics. Number 3, and I think we heard several people say bill or administration or administrative stuff. Healthcare administration costs is a very significant driver we'll be talking about. Consumer demand is also a kind of a newer increasing driver of healthcare pricing as consumers are and the advent of the internet are getting smarter and want more and know how to ask for healthcare services more today than they were able to 20, 30, 40 years ago when they would just wait for their physician to tell them what they thought they needed. And number 5, another core underlying issue is lack of price transparency. And so some of these have a high degree of interrelationship, lack of price transparency being part of that. But lack of price transparency is also a major contributor because without that, it's very difficult to, for the consumer in America to understand how to influence what they buy, who they buy it from, what they should be paying because there's just no knowledge there. That was probably one of the most important things that just blew my mind, again, 20 years ago when I got my fundamental education on the US healthcare system. Is it's the biggest industry in America, but it's the only industry that doesn't operate as a free market. And that was just absolutely blew my mind, but that's a huge contributor to price transparency. So let's dig into some of these reasons a little bit. Market consolidation, probably one of the biggest, if not the biggest contributor to increasing pricing. And this is a great study that was done in 2017 that kind of breaks down kind of the influence or the amount of market consolidation power that different segments in the US healthcare system have been able to muster basically over the last decade plus. And there's interesting. I mean, the study and these guys, this organization benchmarks market consolidation for the Department of Justice and the Federal Trade Commission. So they've kind of built the model that helps the FTC and the DOJ understand across industries, not just in healthcare, what industries and what players or segments within industries and even with companies within industries appear to have too much market power and or monopoly standing. And that's what the DOJ looks at, Department of Justice looks at to determine whether or not, they should legislate against, a monopolistic company or a sector that seems to be colluding. And you can see kind of at the bottom there, the moderate concentration, segment, the high concentration. And then, what's fascinating about is that in healthcare, right, we have sectors that are massively beyond what we would traditionally consider to be pretty high concentration, high, monopolistic segments. What's interesting is that you see the hospital segment obviously increasing their market power over the last decade. Everyone in this class is witnessing that in their local communities, again, as you're seeing hospitals buy up healthcare providers, independent healthcare providers, in particular primary care in their markets. They're doing that, right? The motivation to do that is the more that they can kind of put, the more and more providers they can put into one company gives them more negotiating power with a health insurance company. Because if you're a health insurance company and you want to provide a health plan in the greater Orange County area, I'll make up a geography. The one thing that you need is a lot of doctors that are in network in your health plan, because that's why someone would buy your health plan, is that you have a lot of doctors in it. And in that market, if that market is dominated by one major health system that also employs 75% of the primary care doctors and most of the specialists, that organization is going to have a lot of negotiating power against that health plan to determine the prices that they want to be paid for the services that they want to render. So hospital consolidation, which continues in this country, is a major driver of price increases. Specialist physician increases has been part of that. Specialists across the country are kind of following suit in many cases in certain subspecialties. Subspecialties that come to mind for me are like orthopedics, dermatology, where you have large private equity companies capitalizing the purchase of large numbers of groups in particular subspecialties that they think they can create market power and drive more effective negotiations with insurance companies and thus get paid more. So that's a trend that we're seeing. Insurer concentration in terms of market power has been relatively flat. That's not been a big contributor. You do see primary care physician market consolidation happening. A lot of that's not happening by primary care doctors on their own, though. Typically, it's correlated with, or it's kind of in conjunction with, the hospital consolidation that's happening up here as well. So yes, market consolidation, and the people that said monopoly on the poll, they were speaking to it. This is a big problem and a big driver of healthcare price increases year over year.
In terms of benefit to the consumer, to the patient, I wonder, this is actually a really interesting place to insert a question around price transparency. I know there's been a huge debate and discussion around this, specifically from the hospital side. I, as a patient, will decide to go to X hospital because I looked up on their website and it says that prices are lower. I wonder if you think that transparency would actually allow for some control of this seemingly arbitrary inflation, if patients knew that these prices were being gouged in this way, right? Because the average consumer has no idea that this ballooning has necessarily happened unless they are hit with some absurd bill for a surgery that they've gotten exactly done in the past or something like that. Maybe they're delivering a second child and all of a sudden the hospital bill is much higher than it was in the past. Maybe then they understand this inflation, but in the average consumer, they're not necessarily going to see this. So that's my question. What do you think that transparency debate might bring to controlling some of this?
Yeah, that's a phenomenal question. I think my short answer would be is transparency would help quite a bit, but would not solve the problem. Part of the problem is that, again, the vast majority of Americans that are utilizing healthcare services today do have health insurance. And this is part of the problem in the U.S. healthcare system is that the consumer is, has no training on how to even think to ask the question and consider consider how to ask the question about how much something may cost. So if I have health insurance, I don't have a lot of motivation. It's not that valuable to me necessarily, even if I have a very high deductible, to value price transparency, because I've got this card in my wallet that I'm just going to give to somebody when I have to access the U.S. healthcare system, and it's going to be taken care of, for the most part, or in some part, and I'll have some responsibility, and that's just kind of how it works. So part of it is just kind of is that problem. Now, if there was more price transparency, I think increasingly it will help, because as I communicated and touched on earlier in the discussion, Americans, although many Americans think, well, they get health insurance like everything's just going to be paid for, are starting to recognize over the last 3, 4, 5, 6, 7, 8, 9 years that, well, my health insurance actually has a fairly significant component that I'm responsible for, my deductible, my copays. And so that shift to higher deductible plans and the shift of cost responsibility down to the consumer is actually starting to wake Americans up, I think, to a certain degree, about the fact that, I am on the hook for a good part of my healthcare services cost, even though I do have insurance. So I wonder if I should start to get smarter when I have to use that U.S. healthcare system, because I am responsible for taking decisions and paying for a component of that. Today, people, there's such limited price transparency that they can't really act on that, even if they want to, unless you become a very educated healthcare consumer and can play the game pretty well. I mean, personal story, right? I've got a friend in the town that I live in. They had to have, a normal lab battery done for their annual physical, right? And they went, and they have a high deductible health plan. They went, their primary care physician told them to get the labs done. They recommended a few different places, one of which was the hospital, the other of which actually that was the primary recommendation. So they just went to the hospital and had their labs done. They got a bill. This was actually a story I was talking to this person like about a week and a half ago. They got a bill for like $1,000.13 for labs that I know, being an overeducated healthcare consumer, wouldn't cost more than about $13. If they had gone to LabCorp and just said, listen, I'm a cash pay payer, here are the labs I want to have done. If you know to ask that question, and you do it in the right environment, not in the hospital, but at LabCorp or any number of cash pay lab facilities today, you can save yourself thousands of dollars. So, but that, it's hard to get price transparency on those options today. Even if you ask the hospital how much the labs would be, they probably wouldn't be able to tell you. And quite frankly, and this is kind of the dirty secret, they don't want to tell you, because as they're, with lack of price transparency comes the ability for healthcare providers to raise prices, who ultimately the health insurance companies, right, have to figure out how to bake into their premiums, and health insurance companies, to be perfectly honest, right, are having an economic incentive to see premiums grow because they keep a piece of that pie. So that's kind of the vicious circle that's kind of depressing this movement and desire for price transparency. That makes it more, that's even in today's world, makes it fairly difficult for a consumer unless they really push through and ask the question to understand how they can purchase healthcare more cost effectively. Does that address your question? I don't know if I hit it square on, but.
No, it absolutely does. And I think that's the biggest issue with price transparency, that like, sure, you can issue a price, whatever that might be, but that doesn't equal what someone pays, right? It might not equal your out-of-pocket cost, even if we're talking about payment on behalf of the insurance company for services rendered to you, right? So I think that is the toughest part, and I appreciate your cautious optimism there. We do have a question from the audience. Rachel, we see your hand up. Go ahead and unmute yourself or drop any questions in the chat.
Yeah. Hey, thanks so much, Mr. Lubin, for kind of walking through this. And maybe you'll get to this question a little bit later. Is kind of going off Kelly's question of the price transparency and kind of looking at this graph that, as you know, the market is really inflated and how hospitals are comparing to the other aspects of the care system. I know that with the last administration, the Trump administration, they did sign an executive order to force prices to be made available from all hospitals and care providing settings. And so I'm curious, do you feel like we're kind of jumping the gun by being like, we're going to make all the prices available, we're going to show you how much we're charging for everything, but we're not actually addressing the elephant in the room, which is like administration still wants to be in competition with other hospital systems, you know, private sectors fighting the public sector, you know, insurance companies don't want to lose the hold that they have on these inflated prices. Like, do you feel like just like we're basically just like, we're going to show you the prices, but we're not actually addressing the problem? Or is that just the impression I'm getting because I'm a frustrated, you know, resident physician, you know, trying to figure this out at the same time?
I love the question. It's the right question to be asking. I think that no, I think the short answer is no, it won't address the problem. I think that the other thing that you'll see, and I'm already, you know, all the different chat groups and, you know, that I'm involved in, you know, that mandate does exist, right? Hospitals in particular, right, have to provide price transparency onto a subset of their service offerings. That's kind of step one, and they're being forced to do that. And they're starting to do it. There is so much resistance from them to doing that. And you know, one of the funny things that I see is like we share, and I should have probably pulled in this presentation because this is fascinating. Some hospitals are starting to share their prices, but they're sharing them in ways that are totally impossible to understand. Like these documents that, like, for the life of you, if you spent 6 months trying to, you know, decipher what they're trying to say the price is for, you know, a list of 23 services, you wouldn't be able to figure it out. So I think that forcing price transparency, I think in spirit, it's the right idea. Is it going to solve the problem? No. Is it addressing the elephant in the room? No, it's not. And there's so much economic power and influence in the kind of the medical economic industry today that, you know, that has this kind of whole process locked up. It's going to take some time. I mean, the one reality is, you know, and I'm an optimist too, is that the trajectory of spend is 100% unsustainable. And there's full bipartisan support for that concept. We have to solve this. Where I've tended to see where most of the innovation is, and we'll be touching on this a little bit in the presentation, is not in the public sector, but in the private sector with self-funded employers. And I'll be talking about why we're seeing the most movement there in solving for this issue, and how they are leveraging price transparency productively to help to solve for the problem. So there's segments of the healthcare landscape that I think are driving real innovation, but, you know, a federal mandate to provide price transparency, you know, for hospitals, you know, across a set of services isn't going to do much in terms of addressing the elephant in the room, to your point. But I'm still an optimist, and I'll share some of the reasons why there in a little bit.
Thank you.
Any other questions? Okay. So we're still talking about kind of those drivers of pricing of price increase intensity. The second area that I wanted to touch on, of the 5 that we outlined there, the 3 that I highlighted have the most influence. But, you know, several people astutely said admin costs, administration, I think were some of the answers there. Spot on. You know, we spend more on administrative costs in healthcare. Again, I mean, like, you know, by far surpassing any other developed nation. And there's a lot of reasons driving that. Our admin cost is very significant, and again, growing very significantly as well. If we just kind of parse that down to billing and insurance, kind of insurance billing related costs, BIR, those annual costs that providers, healthcare providers bear, is very significant. I spent a lot of my time in my career and continue to do in the primary care segment. Independent primary care, actually even employed primary care doctors, it's approximately 30 to 35 cents of every dollar they finally get in reimbursement goes to the administration of getting paid. It's a huge contributor to the inflation of healthcare costs. A corollary to that, and I love this chart, is in parallel, we're seeing an absolute explosion in the number of administrators, healthcare administration employees across sectors, just a total explosion of that have, as that segment of the industry, the administration on getting paid, right, continues to explode. And what just kills me, right, is, just look at the ratio, right, of administrator growth compared to physician growth in the US. And I know this chart is is a little dated. It would not look too much different with more recent data. That ratio just absolutely kills me. It should be the inverse, right? But as the way the industry is structured, multi-payer system and private insurance plus public, each one of those organizations having their own rules and billing infrastructure that has to be administered. And quite frankly, more dirty secrets. If I'm a health insurance company in this country today, I'm regulated to only be able to keep a segment of my premium that I'm able to keep for, my admin to provide my healthcare plan, and reasonable profit. And so the only way that I can make that grow every year, right, is by making sure the total pie of spend grows. And again, so, the thing that concerns me is that we think about lack of price transparency, we think about market control and concentration and consolidation happening. And then you think about the entities that are paying for it. There's a relatively tight linkage there in terms of economic incentives that are driving kind of that vicious circle to continue in that direction. And again, that's the piece I think we need to figure out how to unwind. Touching on price transparency, obviously a hot topic. The vast majority of people just have no idea, right? How to, understand how to talk about pricing, ask for pricing, and let alone, even if they did, understand how to use that information to affect their healthcare decisions. We're in kindergarten level in this country of understanding how to think about and understand pricing and how to affect that in my day-to-day healthcare decision making. And this is a little bit redundant from an earlier slide, but same point. It is absolutely stunning what the price disparity is, or spectrum, across everything. There's not a single healthcare service that where you depend, regardless of what market you're in, where the cost of what that service is can vary intensely. One secret, if anybody in this class is not doing it already, is that if you're not doing it already, start to become a smart, educated healthcare consumer. Whenever you need to engage the US healthcare system, you just play the game. It's actually kind of fun of asking whoever you're getting a service from, right? Even if you have health insurance, how much is this? And how did you come up with your pricing? And how competitive do you think your pricing is compared to other places? I also encourage people to, to shop, right? So if you need labs done or whatever it might be, call to, just for the pure exercises of kind of putting a fine point on understanding how prices may vary, or what you may discover is that the clinic or the practice or hospital you're calling either has no idea or doesn't want to tell you. It's fascinating to play that game and just understand, how the provider segment is, it will answer you in those ways. And quite frankly, as a rule, right, if you do ask that question and you do shop, this slide, kind of pays it off. There is a stunning amount of savings to your, to you personally, if you start to become smart. So continue to, I encourage people to be smart, educated healthcare consumers and dig into this transparency issue as a consumer of healthcare.
Before we get to the next slide, I actually have a question. How do you see the consolidation of the markets also affecting administration costs? Does it have no effect? Is it actually reducing administration costs because now you have people within the same systems being able to use the same employees, or it's not related at all?
It's a really, really good question. I don't have a perfect answer to that, but from what I've seen, it can help to bend the curve on administrative costs because, correct, you are consolidating administrative functions across many practices versus having them be, located individually, right? If you buy 10 primary care practices, that you can then consolidate their billing organization into one organization. I think that helps a little bit in terms of kind of bending the curve on administrative cost and spend. But the intensity of that work is also relative to a healthcare provider. So, and even if you're consolidating all those people, from 10 practices into one centralized billing organization, the amount of work stays the same. If you're still billing, for example, for those 10 providers. So I think you can drive some efficiency, but it's not like you can't make step change improvements in efficiency as a result.
Thank you. That made sense.
I thought I'd share this with you. We've talked about this a little bit, but these are kind of snapshots, I think about a week and a half ago, of the stock charts of 4 of the largest private health insurance companies. And just to make the point, and I'm not here to throw insurance companies under the bus. They're actually close partners of ours at Aledade, and they in many ways are trying to solve this problem too. But they're doing okay. Despite all the trends that we're talking about, they continue to do pretty well, which is kind of an interesting data point on its own, I think. Okay, so want to change kind of the direction of the talk a little bit to, how do we solve this problem, right? And this is really kind of the heart of our talk. We know what the problem is. We've been talking about that. The market's reaction to this, right, which is the heart of today's discussion, is we got to fix it. And one of the key things that we know that we can do that's profound, that can have pretty profound impact, is to shift how we pay for physicians or pay for healthcare services. Historically in America, the vast majority, if not all, of healthcare services are paid on a fee-for-service basis. You do something, you get paid. And the basic concept, and in many cases, I think that that's actually appropriate. But certainly, like in routine care environments, it drives all the wrong incentives, because if I get paid when I do something, then I'm at least on the economic front, I'm incented to do more things. And that economic incentive, which is kind of a byproduct of the fee-for-service payment system, is a huge driver in our total spend growth. And so huge, big influence and big changes happening as we sit here today. Our business is really at the heart of it, to try to shift away from the fee-for-service payment model to paying for value, and making that shift. So that's a big shift that we're into right now in the U.S. healthcare system. If you're a doctor in America today, you are in the middle of that shift right now. All of your insurance companies are trying to move you to pay you less fee for service and more based on value. And I'll be getting into some details about what that looks like in a second. So that's the trend and the reaction that a lot of the financiers of healthcare, whether it's Medicare and the public sector, who are the big drivers of this initiative, quite frankly, who are then also being followed by the private sector insurance companies, which we just showed a slide on a second ago. Okay. This move from, to value-based care isn't, I and many firmly believe is not a one-time event. It is very much the future of how healthcare is going to get paid in this country, and it continues to move forward in that regard. As I mentioned earlier, this concept of starting to pay for value versus paying for volume in the fee-for-service model has strong bipartisan support. These models that have been in test and in pilots for the past couple decades are really starting to, some are starting to demonstrate real potential in terms of reducing healthcare spend, which we'll be talking about. And so there's a lot of movement, and there's now starting to become fairly good data to demonstrate the impact that it's having in terms of changing the payment model from volume to value. The federal government and the Center for Medicaid Services and their innovation arm, CMMI, really have been the pioneers in this shift in terms of paying from volume to value. They really have been the pioneers, and they continue to be the pioneers in that space. The private health insurance companies have been fast followers in their models. They have not been the pioneers; they've been the fast followers. As Medicare has demonstrated through pilots and is now mainstream on many new advanced or alternative payment models. So that's been kind of the trend there. CMS is really trying to solve for three things. You guys are familiar with the triple aim, right? We're trying to figure out payment models that improve population health, the experience of care for patients, and reduce per capita cost. So those are the objectives. A lot of new primary care payment models disproportionately focus on the primary care segment. And the reason why that's the case is, quite frankly, right, primary care only accounts for a very small, percentage of total spend, yet primary care doctors in this country have a tremendous influence. They influence over 85% of total spend in the country. They've got the least to lose and the most to gain. They're also the best positioned to economically benefit from this move for paying for value as well. But most and the most successful new alternative payment model approaches have been primary care focused, and it's for that reason. So I have a lot of, it's interesting. I mean, primary care doctors in this country over the last 20, 30 years really been at the lowest end of the totem pole in terms of influence and certainly in terms of pay. The country is now waking up literally today to recognize that they need to be at the top of the totem pole if we are to affect the problems that we've been talking about. I'm very encouraged by that notion in that movement. CMS, Center for Medicaid and Medicare Services payment reform goals, right? Just reinforcing the notion I just had. Historically, the vast majority of how Medicare paid for services was fee for service, with no link to quality, no link to value, no link to cost savings. Their vision and goal is to dramatically shrink, almost eliminate, how they pay for services away from fee for service into different forms and newer forms of alternative payment models that pay for value. That's their vision, and they are marching down that path with good success, and consistently we'll be digging into that here. So this is kind of, CMS's stair step to value. So what are they trying to do? You can't, number one, you can't tell a doctor that today we're paying you fee for service, but next year we're only going to pay you if you reduce the total cost of care for the patients that you're managing that are Medicare patients by 10%. And if you don't do that, we're not going to pay you. Or if they spend more, then you're going to owe us money. Can't do that. You can't force a change in how you pay healthcare providers that rigidly. So they call it a glide path, right? We're kind of easing our way and easing healthcare providers down a path over the course of years into new payment models to achieve kind of that vision that they have to move away from paying for volume, aka fee for service billing or payment. Phase one is kind of where we've been historically, right? Paying just fee for service, no link to quality and value. We've moved into category two. This is pretty widespread across both how Medicare as well as private insurance companies pay today, paying fee for service, but also having some programs. Well, they can pay you a little bit more if you satisfy certain quality measures or take care of sicker patients in certain ways. They'll give you bonuses. So that's kind of the first phase of easing you into value. Category three, alternative payment models built on the fee-for-service architecture. We're also there now today. This is where we live in our business today with our provider partners, where we're going to continue to pay you fee-for-service. We may start to decline or reduce the amount that we're paying you fee-for-service, but we're going to start to give you a lot more opportunity to earn more if you're able to reduce the total cost of care for the population of Medicare patients, in this example, and you're successful in doing that. And then, again, the ultimate goal is to get to category four, which can take several forms, but essentially, we're going to give you a flat amount of money each year for each one of your Medicare beneficiaries, and it's your job to take good care of them. And if you have to spend more, it's coming out of your pocketbook. If you spend less, well, then you create some profit. So that's the glide path to risk and kind of stair steps to value concept. I'm not going to go into too much detail on this because I've got some others coming up and I want to be cognizant of time. The other thing I wanted to share is that kind of along that kind of stair-step vision, right? These are the main programs that CMS has implemented in pilot form, and then some have gone to mainstream and continue. In that, that are the actual programs to kind of move practices in the Medicare that have Medicare patients down that process. Starting with the kind of the pioneer ACO model, and I'll be talking about what an ACO is in a little bit. Advancing that into what's called the Medicare Shared Savings Program, which is also designed for accountable care organizations. Again, more to come on that in a second. The CPC Plus program, and then it advanced to CPC Plus, then advanced to CPC Plus. Comprehensive primary care program were introduced. The next gen, accountable care organization model, which was really for health systems, actually ends this year. Was not that successful. Was along the stair step, and as we get into today's world, just quite frankly, very very recently they announced a couple of pilot programs, Primary Care First and the Direct Contracting Program. Again, I'll be talking about what these are in a second. And the Pathways to Success, which is kind of the next stage of the MSSP program. So again, these are the actual programs that they've deployed to healthcare providers to start to move them down that stair step to value approach. So let's talk about some of those in a little more detail. I've said the word ACO a few times. What is an accountable care organization? This is a key concept in both CMS's eyes as well as private insurers' eyes, in terms of how they start to move providers down this path. So an ACO, really is a group of healthcare providers. It could be hospitals and specialists and primary care doctors. It could be just primary care doctors. But in essence, it's a group of providers that come together, that agree to work together to better deliver more integrated care and collectively take responsibility for the cost of those patients and do the things that they think, right, are the things that are going to make a difference in helping to deliver better patient care, at the same time reduce the amount of total cost that those patients will incur year over year. So it's kind of an organizational approach versus a single practice approach. There are two forms of ACOs in the country today, working in the Medicare program. Ones that are called low revenue ACOs. They tend to be primary care physician only ACOs. So, think 10, 15, 20, 30 independent primary care practices coming together in a community and forming an ACO and then contracting with Medicare in an ACO program. Low revenue ACOs are providers that collectively incur less than 35% of the total costs of the Medicare patients that they're caring for. High revenue ACOs are organizations that incur greater than 35% of the total cost of the patients that they're managing. They're referred to as high revenue, and they typically include, all segments of healthcare provider, hospitals, specialists, as well as primary care. What's interesting, really interesting to see is that, the Medicare Shared Savings Program, which is really the marquee CMS ACO program that has done the best, is, if you take a look at the high revenue versus the low revenue ACOs that have participated in it, you'll see a stark contrast in their success in that program, where low revenue ACOs have been vastly more successful in reducing costs, the total cost of care of their patients, compared to high revenue ACOs. And quite frankly, the biggest driver behind that is if I'm a high revenue ACO, so it's a hospital and specialists, or like a large integrated delivery system that's decided to move and try to participate in the MSSP program, they're challenged with an economic incentive program where hospitals stay, right? They make their money by trying to have more utilization in the hospital, which happens to be the highest cost place to deliver care. So, being involved in a program that's designed to reduce costs, they struggle in that environment because of the economics of their system. So low revenue ACOs, primary care driven organizations coming together are proving to be much more successful at reducing the total cost of care compared to hospital driven initiatives. The Medicare Shared Savings Program, I've talked about this a couple of times. What is this thing? If you are going to be a doctor and you're going to be in primary care or even non-primary care, you will see this program and start to run into it as you are out in the marketplace. The Medicare Shared Savings Program is by far the largest and most successful alternative payment model program Medicare has launched. It allows physicians to kind of progress down what I'll call the risk continuum, which I'll talk about in a second, kind of at their pace. It also offers the greatest opportunity for financial reward for providers that are operating in it. So this is a tactical example of what Medicare is doing and how they would pay you as a physician if you were operating in an ACO that was operating in the Medicare Shared Savings Program. And what they do is, like in year one and two, typically, they'll start you by saying, listen, we're going to continue to pay you fee for service. But if you would share, if you reduce the total cost of care for the Medicare patients you're taking care of, we will share part of that savings with you. And in fact, we will share 40% of the total savings that are generated back to you. And, and so that sum of money can actually be very, very significant if you're successful. It's an upside only track. These are kind of the tracks, meaning that if the total cost of care increases, you don't save money, they actually increase money, you're not on the hook to pay anything back. Keep your fee for service revenue. You're not going to participate in the shared savings. There were none, but you're not at risk, financial risk, of actually having to return money to Medicare in that track. But what Medicare does is they require you every 2 years to kind of move down to the next track. And as you move down to each track, what happens is they start exposing you to the opportunity to achieve, take home more of the shared savings that you generate. But at the same time, the other shoe that drops is, but although you can earn more if you help to save more, we're also going to put you at risk where if the total cost of care increases, right? So your patient spent more, you're actually going to be on the hook to pay back Medicare up to 30% of the losses that were incurred that year. So they kind of, they kind of move you down this path where, yes, I have the opportunity to earn more. And if I do a great job with my fellow physicians we save more money, we'll be able to keep more of that savings. But at the same time, we're also exposed or on the hook for, if there are losses, again, if the total cost of care increases with the patients we're managing, then we might be exposed to having to pay that back. So that's the concept behind this program. Our company actually partners to create ACOs, work with independent primary care physicians only, and work in this program. And we've had tremendous success in it working with providers, but you really got to know what you're doing. It is kind of the headline, and that could be a whole nother lecture unto itself. But this is a really good example of how Medicare is really trying to change how they pay for care, linking that care to the reduction in the total cost of care, and allowing healthcare providers to participate in that savings, which again can be very, very significant. In fact, it could be 2, 3, 4 times what the doctor's making in their traditional fee-for-service billing in savings if they're successful in this program. How does the Medicare Shared Savings Program work kind of in concept? So again, it's, ACOs are formed. So doctors come together that want to participate. And those primary care providers agree to take responsibility for the total cost of care accrued by the subset of Medicare patients that they're attributed to. Those physicians work throughout a calendar year, typically, to deliver great care and smart, efficient care and make sure that they're referred appropriately and discharged and handled, out of the hospital, to try to keep them out of the hospital as much as possible, care for chronic disease as much as they can. At the end of that year, Medicare tallies up how much money those patients cost Medicare, and they compare that to a benchmark. And again, benchmarking methodologies could be a whole separate lecture, but in general, in the MSSP program, they look at the last 3 years of those patients' spend, average it, and they say that's the benchmark. So in this performance year, if we spend less than that, right, then there's savings generated. And so they do that math. And if that total cost for those patients is less than the benchmark, then they'll split that savings with the physicians. So that's kind of how an ACO works and how the payment model works within the context of an ACO in the Medicare Shared Savings Program. This is just a demonstration of what the actual economics could look like for a single primary care physician operating in the Medicare Shared Savings Program. A little example here, let's assume that physician has 300 Medicare patients. Let's assume that throughout that performance year, those patients cost Medicare, about $9,500 for the whole year. You know, multiply that by 300, and there was the total cost of care for those 300 patients was $2.7 million. Let's assume Medicare expected to pay $10,000 for those patients per patient that year. So you can see that, you know, there was about $150,000 worth of savings that ACO and that physician was able to achieve. The payer, in this case Medicare, would retain some of that savings. They don't give all the savings back to the provider. They retain some of it. Typically it's 50% in the Medicare shared savings program tracks. So the payer, in this case Medicare, keeps 50%, and the remaining, and then there's investments, right, that the ACO needs to make, that will take up some of the savings that's returned to the ACO, and then the balance is distributed amongst the doctors, that they would then achieve, in addition to their fee-for-service revenue. So at a high level, right, this is kind of how the economics work in this alternative payment model, and how it can, you know, it can add significant revenue to a healthcare provider who historically was just paying for, you know, getting paid on a fee-for-service basis. This just kind of shows how those economics can change for a typical 2-physician practice. In the Medicare shared savings program, you know, in our world, and this is our data at Aledade, last year, the doctors participating in the Medicare shared savings program in our ACOs achieved, on average, a savings check. They were paid $191 per Medicare patient for the year. That was the shared savings that was returned to them. And so, you know, that's kind of what's articulated here in the blue section of this graph. This is their average fee-for-service revenue. So you can start to see that the shared savings, the value-based payments, for a typical 2-physician practice can start to dwarf the amount of money that they would otherwise make in just fee-for-service. And again, think back to the major problem, that $1 trillion worth of waste. There is an enormous amount of unnecessary utilization and spend that Medicare in particular and commercial insurance companies are starting to do as well, are starting to allow providers to get paid for the good work that they're doing. And the economics of that new value-based payment and these alternative payment models can be very substantial and be a lot more than what they were achieving in fee-for-service. So this is the world that we're in today, and what some of the economics look like, and why, quite frankly, not only is it attractive for the healthcare system, because it's training doctors not to just deliver services, but think about how to deliver services that are cost effective, that are efficient, have them be smart, and think about their patients globally, and making sure that they're in the right settings of care and not in settings that are too expensive, making sure they're not, you know, unnecessarily using the ED room, unnecessarily, you know, getting readmitted to the hospital. It's creating a whole new mindset for physicians about, you know, thinking not just about delivering great care, but delivering great value too for patients. That's, you know, that also allows them to, you know, improve these economics. Again, this is Aledade data here. It's interesting to see. These are across about 25 different Medicare shared savings programs, ACOs, that we operate in, and what their quality outcomes are, in terms of utilization changes. One of the things that you'll see is that in our ACOs, and this is pretty common, there's actually more utilization of primary care, and that's a good thing. We should be using, you know, primary care as much as we possibly can, but with that increase in primary care utilization, we're driving significant reductions in ER utilization, in inpatient utilization, in skilled nursing days, as the physicians operating in our ACOs, again, are kind of changing their mindset away from, I'm just going to see and do what's in front of me with the patient, to how can I think more globally about my patients and make sure that they're not utilizing the healthcare system appropriately. So these programs are driving really material differences in patient outcomes, in utilization trends, in high cost utilization trends, and ultimately, you know, really improving the economics for primary care physicians as well. How are we doing on time, guys?
We're doing great.
Make sure we get to our exercise at the end.
Yeah, I think we're doing great. We're looking at the last 15 minutes of our session. So I don't know where you are on your slides.
Yeah, let me, I might just move quickly through. There's a fair amount of density. I was gonna kind of touch on the most recent CMS Advanced Payment Models These slides are for distribution. Obviously, I think I might move past a couple sections here. The slides are relatively self-explanatory. I'm always a resource if people want to learn more about stuff, but I definitely want to spend some time on the last section, kind of the thought exercise. So what I want to do is I want to get beyond kind of the CMS world, which I've been talking about, and their value-based care philosophy and program, and results. And I want to spend a couple of minutes talking about the private sector, and then kind of go into our last exercise. So as I mentioned earlier, the concept of paying doctors for value versus for volume is being largely driven by CMS, but it is quickly being fast followed by the commercial insurance industry. And as I mentioned early in a discussion, we're also seeing a lot of innovation in alternative payment models being pioneered and driven by companies, corporations, of all size in the country, who are on the hook to pay for their own healthcare costs that are driving a lot of innovation. I want to get into that for a second here too. So as we talked about earlier, the private sector, right? That finances about half of healthcare spend. And that's companies, right? That you may be a member of, that you get your healthcare benefits from. They are a major and unusual and very major component of healthcare spend in the country. Companies in America have basically two strategies they can deploy to provide you with healthcare benefits. One is called self-insurance, and the other one's called, it's referred to as fully insured. In the fully insured model, that's essentially a company that calls up Kaiser or calls up United or Anthem or any major insurance company and just says, can you provide healthcare plans to my people? And the company's only on the hook for, right, the premium cost that they're going to pay all or a portion of for their employees. In that model, they have no control over the cost of those premiums. They can't negotiate them, nor do they have any control over the cost increases in those premiums over time. The insurance companies dictate that, and that's what you got to pay. That's the fully insured model. In the self-insured model, it's very different. In the self-insured model, companies actually essentially become healthcare plans onto their own, where they don't pay premiums to a third-party insurance company. They become the insurance company. So, and most people out there that get their healthcare benefits don't know whether their company is self-insured or fully insured. But in the self-insured model, and this is really important, the company pays out of their own pocket for the healthcare costs of their employees. Because they look at the equation, they say, well, we could either pay, a healthcare premium of approximately $1,600 to maybe $2,000 per family to a health insurance company, or we could take that money and just put it in the bank. And we can design a healthcare plan and figure out ways to incent our employees and take control over that spend to try to spend less. Because we have the control over how that gets spent and the kind of levers that we have to make, to drive behavior and healthcare utilization. So in America, right, of half of Americans that get health insurance through their companies, about half of those companies are in that self-insured model. And that's where most of the innovation is being driven on price transparency and all the other levers that are trying to address the elephant in the room. I think I talked about this, but if you're self-funded or self-insured, you pay your fixed costs, but then the rest of it, you control how you spend. And fully insured, you have no ability to affect cost. In the self-funded employer world, again, employers have full control over how they spend their healthcare dollars. And it's that claims expense bucket, right, that they have the ability to control. So this is where we're seeing most of the innovation in this world. There is a lot of innovative groups that are working with self-funded employers to design and architect brand new health plans that, in many ways are essentially disintermediating the third-party payer system, and are building plans that are firmly founded in concepts like price transparency, and in new ways of paying doctors that are not through a third party, paying them directly. Because when you take the third-party payer out from in between the person who's paying for healthcare and the healthcare provider, think about those drivers of cost, right? All that administrative cost, the lack of price transparency, thus you don't know, really what the true price is. All of that gets taken out. And so you actually have pure price transparency. You remove a lot of unnecessary, billing and administrative costs. And so your total healthcare spend can go down really dramatically. Here's some case studies. I won't go through them in depth. You guys can read them on your own, of some very innovative new healthcare plans who have applied these principles and are spending significantly less as a result. Quickly touching on a model of in primary care that's fairly innovative. There's actually a fairly significant movement happening in the independent primary care sector where, and this was a previous company that I was with prior to Alidade, it's called direct primary care, where you have primary care physicians across the country that are like, listen, all I want to do is take care of my patients. I can't operate a practice economically, let alone all the other administrative burdens that the insurance companies are making me kind of jump through hoops on, that where I'm spending 60% of my time on dealing with those issues versus 100% of the time I'm with my patients, which I really care about. They're basically revolting and going, listen, I'm out. I don't want to work with any insurance companies. I want to care for patients directly. And in this direct primary care model, the patient would pay them. It's like a Netflix subscription, right? So the average pricing, it's a membership model. Average pricing in America is about $60 to $70 per person per month, and it's all you can eat. And because I don't get paid on a fee-for-service basis, and so you have to come to the office, and that's how I get paid because the insurance company says you have to come to the office, and so I have to bill. All that goes away. Call, text, email your doctor, come in for appointments whenever you want to, all for a flat fee. And so this is an example of kind of a reaction, right, to a lot of the problems that we're seeing that a segment of the primary care market starting to gravitate to, that quite frankly, employers and self-funded employers are also working extensively with, because it solves for a lot of that elephant in the room issue that I'll parrot back from one of the students that mentioned that earlier. So there's some really interesting, powerful innovation that is going right at, kind of solving for these challenges. That's happening kind of outside of what I'll call the status quo, kind of medical insurance market consolidation world. That's kind of interesting, and I encourage people to take a look at. Okay, timing. What do we have? Just a few minutes, right?
Yep. So,
this might be a little bit much for today, Kelly.
okay.
Given the time that we have, maybe we just open it up to questions.
Yeah, we could. I mean, it's a relatively small group. We have 16 other students, not counting you, Reese and I. So if we want to just invite for kind of group discussion here, we can, to really solidify all of what was discussed. This is actually a really good case, so I do want us to address it. So we could do that.
Let's try that.
Yeah, sure. So if you want to go ahead and read our brief, and I can offer some of the questions to the audience.
Yeah, so here's the thought, right? So we've been through a ton today, but I thought I'd kind of challenge you guys with a little thought experiment and see where people's kind of heads are, heads are on this stuff. But here's a brief, and it's actually a relatively real situation. This is what municipalities, cities, even companies are dealing with every year, right? As they think about their healthcare spend challenges that are going up. But here's the brief, right? So the city of Sacramento employs 140,000 people, and they have a self-funded health plan, right? So they control how their health plan is designed, and they're on the hook for spending, and reimbursing dollars for healthcare services. The health plan has always paid its providers on a traditional fee-for-service basis. Their healthcare expenditures have been growing unsustainably, between 7 and 9%, year over year for the past 5 years, and their employees, / patient outcomes have been at or below national averages on most measures. And the network providers that are in their health plan, by the way, have no experience with alternative payment models, and they're very risk averse. So the problem is that, the city of Sacramento is going to, they won't be able to offer healthcare benefits if this continues for the next 5 years. They have to solve this. And they want to take a look at solving it by trying to figure out how they can pay healthcare providers differently. So the question for the team is, right, for the class is, you've been asked to develop a new healthcare payment model and an approach that will slowly shift the cost, risk, and responsibility from the city, who just gets a bill every day and they've got to pay it, right, to the network, to the providers in their network, to better align, incentives in terms of for the providers, to reduce healthcare spend and improve health outcomes and reduce that annual expenditure growth by, geez, anything. But if we could get it down to 1 or 2% every year, that would be pretty amazing. So, I mean, the question for the team is I mean, that's kind of a big ask, but what do you think, what would you need to, like, if that was the problem, how would you approach that problem? How would you start thinking about it?
And people, feel free to unmute yourselves and contribute here. Otherwise, you can drop thoughts in the chat. The first question, if we're trying to keep costs down, incentivize our providers to help keep said costs down while improving outcomes, what do we need to know first? What do we need to know about our population in order to make that happen? I certainly have my thoughts, but this is not just for Reese and I, so the floor and the chat box is open for people's thoughts. What do we want to understand first before we think about immediate solutions? And this is not on poll everywhere. This is just within our chat box here. I know one of the things I certainly want to think about is, oh, great, Joanna, the individual's exactly, yeah.
Yes.
What are people sick with, right? What are we paying for? So Joanna offered the individual's chronic health conditions. How much are they using primary care on average? Because we have to think about what providers might be driving up costs. Great thought. What is their current ER utilization and how can we potentially bring that down? That's a big, big cost driver that's potentially avoidable. Great contribution, Joanna. Great contributions. I certainly was just going to offer, we need to know what people are sick with. What are they presenting to their providers for most? I think I'd also be interested in understanding, great, Hayen offered the breakdown of costs. So where is money going in terms of the employer? What is the city of Sacramento paying for? Sure, absolutely. I'd be interested to see that for the consumer, the patient, the employee too. How much are they sharing the cost with the employer? Are they paying a lot of money out of pocket? So we really need to figure out for us as a city of Sacramento how to fix this, or is this something we could potentially share with the consumer or patient? That's a great thought.
Going back to our previous lecture, I know something that I'd want to know is a stakeholder analysis in terms of who are the players and increasing the cost and who would be interested in decreasing the healthcare costs in that area.
Yeah, absolutely.
Good. Excellent questions.
And then this is the big question, the second one. What would our new model look like, right? Once we understand what we're spending money on, what's the cost to the city of Sacramento, what's the cost to the city of Sacramento employee, how much are people utilizing primary care, how much are people utilizing the ER? Any thoughts on what we could do better? We've heard about a couple of different alternative and advanced payment models in this session today. Any thoughts of what the city of Sacramento could pursue? I certainly have an idea. Instead of billing fee for service, you can bill fee for outcomes. That has been a really interesting model within the Kaiser system. There have been some incentives developed in order to kind of cheer on some of the providers that are, for instance, keeping their panels average A1C, hemoglobin A1C lower, so there's a whole bunch of other factors that contribute to why someone's A1C might be higher, but incentivizing outcomes instead of incentivizing service could be a thought. I've also seen, so Hayen asked the question, what specific metrics could be used to measure outcomes? It depends on the outcome. For my example, in hemoglobin A1C of being an output, just for reference, that's a marker we use to really track progress in terms of treatment of diabetes and assess risk associated with diabetes. So to your question about what specific metrics will be used, the A1C is a metric, I would say, and the outcome would be potentially decreased cardiovascular events. The outcome could be fewer people requiring cardiac catheterization. The outcome could be fewer ER visits related to diabetic ketoacidosis, et cetera. So this is getting really medicine-y, but I think that's also a really important point, that these metrics and these outcomes should be dictated by providers. Sometimes they're dictated by people that might not have the clinical sense and may not be able to align what's happening in the real world in a clinical setting with payment, right? There tends to be a misalignment there sometimes because you're not necessarily bringing providers to the table to dictate exactly what those specific metrics would be. So that's a question you should keep, that you should always bring to the table hand in terms of how we make decisions. Any other thoughts about payment model design? How could we reduce cost growth? How could we improve outcomes and reduce spending?
I think it also important to like a payment model design like that would be to have a risk stratification. So for example, if someone comes in and they have really, really bad diabetes where their A1C is like 15, normally we'd like to see it where, you know, it's somewhere around 7, 6. And if we get them down to 9, that's huge. But 9 is actually considered like still to be very high. And I think that sort of risk stratification, I think, would be very much needed in those sort of models.
That's right. Who are the patients? Who are the employees that are driving, you know, all the costs? Usually it's always an 80-20 rule, right? Where 20% of your employee base is driving 80% of your costs. So that's a key input to understand into strategy for sure.
Yeah, and I think there's a lot to consider here. In our previous talk about stakeholder analysis, there are a number of different stakeholders that you have to consider. So the city of Sacramento is responsible for paying for health services that their employees need, right? And they have to figure out, as a city of Sacramento, who all they need to align in order to bring costs down, because it can't just be a one-pronged solution, I think, is what we've gotten at with much of the discussion from Mike today. So another thought or another question to bring us to this, to other answers here, especially looking at question number 1, 2, 3, 4, 5, what medical specialties might we be thinking about if we did want to do some sort of outcomes-based incentive model or some other alternative payment model? Who do we need to think about? Who all do we need to think about in terms of our stakeholders here? What medical specialties would we need to engage potentially as a city of Sacramento to potentially keep costs down?
You know, this didn't come up earlier in a way that we can change the payment model design, but the whole time I'm just thinking, you know, incentivizing preventative care methods, and that kind of will trickle down into improving outcomes, especially in a care system that right now is very focused on intervention. And so the medical specialties as a result, kind of going back to Mike's lecture, would be more on the primary care side, right? So we're talking about our pediatricians, our family medicine, our GP, our internists, and in some cases, depending where you are in the country, your OBGYNs. And then going on to the other care specialists and really making sure that they understand the necessity of preventative care rather than reactionary care. Because that's where a lot of our funding in the healthcare system is coming from right now.
That's such a good contribution, Rachel. And I think that that could be part of your payment model design. If you decided that you wanted to allocate some dollars towards, say, gym memberships, that's not unprecedented for plans to offer benefits that include the gym membership, the Veggie RX program, the healthy eating guide, the access to a nutritionist or dietitian. Like, those are not unprecedented places where plans can spend dollars, or where an employer might decide to develop a relationship with another entity in order to bring general costs down. That's a great contribution.
That is, and I mean, in tangential to that too, part of the research we probably want to do up front is just taking a look to see where the healthcare utilization is happening for the employees. And how does that break down? And how much of it is in primary care versus specialty care? One of the trends that you'll always typically see is that there's enormous amounts of unnecessary utilization happening outside of primary care that should be, that primary care is more than equipped to be able to handle. which then would help you start to understand, well, I wonder how many of our employees actually have a real primary care relationship, and have a primary care home. And oftentimes, more than often than not, you will find that many of them don't. So man, we got to, so if we're going to change anything, we got to get people, properly linked with primary care, in order to change, before we change anything, because it's all going to start there. Yeah.
I think that's a really good dovetail into the last question that we have here, and maybe the last question that we offer for discussion right now. How would you engage the providers? Similarly, I want to add to this question, and then how would you engage your employees? If say our end goal is to better engage the primary care infrastructure in the city of Sacramento, how could we both better engage our providers to ensure that they would embrace this new potential influx into the primary care system? And how would we incentivize or encourage our employees to engage with the primary care infrastructure too? Let's call upon our Cotter's model in our last talk. Let's call upon our theories of change in our last talk. How could we better engage both parties here? Okay, I got a direct message here. Direct messaging. So I think what this person might be implying is like literally sending a mailer or something directly to the provider saying this is what we're doing, or a mailer directly to the employee saying this is what we're doing. Okay, and I got a yes. So yeah, that's a thought. That's a thought. Great idea.
I also received a message. Someone had said building a coalition with the physicians. I think that would be extremely key.
Love that thought.
To the table and making the decisions about how we spend our dollars. Absolutely.
Together, right? Engaging them, having them have a seat at the table, looking for them for leadership. I think that's a really important insight, a very powerful insight. These are tough problems, right? And they don't want to be dictated to. So collaboration on it. It's great.
Amazing. Well, this is a really good discussion for us, and I hope people have a really broad and tangible understanding of how complicated this system of financing the healthcare infrastructure can be. You put it in terms that I think were a little bit easier for us to grasp in terms of how cost ends up so high, because I think in almost every lecture we'll have and that we've had, the first slide has always been we spend too much and we get poor outcomes, right? And so I think this helped us understand some of the different cogs, right, in that larger wheel that is churning this horrible financial trajectory. Thank you, Mike, for being with us today. This was great. And if you miss any part of this, just know these sessions will be recorded. They'll be on our Facebook. We are collecting post-lecture feedback, so drop them in our check in the chat box that Reese dropped the link there. And these slides are made available to our formally registered students on Canvas. If you do want access to any of the slides from our sessions, just send us an email and we'd be happy to send them. Thanks for being with us today, though, Mike. Appreciate it.
My pleasure. Thanks for everybody for engaging. Important stuff, and thank you for your time.
If you're staying on with us, just know that we have our dinner break coming up here, and then we'll join back with a really cool talk with Tony Eiton about why America decides to spend its money where it decides to spend its money. So join us at 6 p.m. for that talk on America's social contract.
Hey, Kelly, just a reminder to stop the recording.